Okay, we have currently 18 people. I'm admitting them, so maybe Daria, you can.
Okay. Okay, hi everyone. I'm glad to meet you here and to present to you our webinar from ERN GUARD-Heart, which is for our Ukrainian colleagues to present to them our possibilities and how we can help, interact, and also we will present a few clinical cases. So must be noted that this webinar will be recorded. So if you have any objections, please let us know in advance. And even though this webinar will be in English, but I will be also sometimes switching to Ukrainian to say a few words. Доброго дня всім глядачам нашого вебінару. Дуже рада, що ви змогли до нас приєднатися. Сьогодні ми будемо говорити про можливості для українських колег, про те, що таке ERN GUARD-Heart, як ви можете користуватися можливостями від ERN GUARD-Heart і чим ми можемо вам допомогти. Цей вебінар буде в цілому англійською мовою, але я буду іноді переходити на українську мову, і також ви можете питати і писати запитання в чаті українською мовою, я буду їх перекладати на англійську, якщо необхідно, або писати вам також українською мовою в чаті відповіді. So, our plan for today is, first of all, this webinar will be moderated by me. I'm Daria Kramarenko. I'm an MD from Ukraine, and I'm doing my PhD at Amsterdam UMC. I would like also to present our ERN expert that joining us today. So it's Professor Dr. Artur Wilde, ERN coordinator, professor in Amsterdam UMC, and cardiologist. Also, there is Associate Professor Dr. Elena Arbella from Barcelona, that is also a lead of the thematic area 1 at the ERN GUARD-Heart, familial electrical diseases in adults and children, and Professor Dr. Georgia Sarquela Brugada from Barcelona, and she's also a lead of the thematic area 3, special electrophysiology conditions. У нас на вебінарі буде 3 експерти, тому якщо у вас є якісь запитання, ви можете написати в чат, і ці експерти зможуть дати на них відповідь. Our agenda for today is, first of all, it will be a presentation from Professor Artur Wilde about ERN GUARD-Heart. Then we will have 2 clinical cases. One will be presented by me, and another one will be presented by Dr. Malou van de Boeghart about obstructive HCM without identifiable mutation. If we will have enough time, we will present, also Professor Artur Wilde will present genetic testing in countries with limited possibilities. If we will not have enough time, we can plan this presentation at a later time. And there also will be Q&A session, so feel free to write in the chat your questions. And when we will have Q&A, so after each clinical case, we also will have Q&A session, I will write them out loud and we will discuss them. And at this point, I would like to give this word to Professor Artur Wilde and to his presentation for ERN GUARD-Heart.
Thank you very much, Daria. Marie, you have to switch the slides. Welcome, colleagues from Ukraine and elsewhere. So my name is Artur Wilde. I don't see them yet.
Okay, let me, 1 second. Yeah, can you show them now?
Yeah. So my name is Artur Wilde. I'm a cardiologist in Amsterdam, and I'm coordinating the ERN GUARD-Heart since the beginning in 2017. The next slide, please. So first, a few slides on what the ERN is and how we work. ERNs in general are a network of healthcare providers across the EU focused on rare and complex diseases, so that includes all rare and complex diseases. They are established by the European Union Commission in 2017 to improve diagnosis, treatment, and knowledge sharing, and it enables a collaboration between expert centers across the EU and Ukraine in particular in this in sessions like this one. Why we think ERNs are important? First of all, it's of course that rare diseases affect a small percentage of people, making expertise scarce. Expertise is scattered throughout Europe, and ERNs ensure expertise and resources across borders. And it also strengthens cooperation between clinicians, researchers, and patient organizations. The next slide, please. There are 24 ERNs on all diseases, and they are divided into 24 ERNs, and there's one on GUARD-Heart. Every ERN has a coordinator, and the subdivision throughout European countries is given in the blue box there. I'm based in the Netherlands, so I'm one of the 7 ERN coordinators in the Netherlands on rare cardiac diseases. The next slide. We are in total at this moment 43 hospitals divided in 16 different European countries, and there are also affiliated partners, and that are 7 in our case. And an affiliated partner is a center and healthcare provider in a country that is usually at the smaller site, so the number of patients might not be enough to qualify for a full member, but affiliated partners more or less have the same rights and obligations as the full members. So in total, we cover 16 plus 7, 23 European countries, all in the European Union. The UK was one of them at the start, but they dropped out after Brexit. The next slide. These are the different centers. I don't think we have to go through the details. If you want the information in particular, we can send it to you, and we can also spread these slides after the meeting, so you will have it all at your disposal. The next. The coordination office is in Amsterdam, in the Netherlands. So I'm the coordinator. Dr. Ahmad Amin is a cardiologist in Amsterdam too. He's very important in the whole structure of this ERN. And we have the luck of having 2 project management colleagues, Marie Murel and Adriana Planinic, who is based in Zagreb. The next slide. There is a project from the EU which is specifically meant for support for Ukraine, and the EC support, European Commission support, is a legal agreement allowing the use of CPMS, that is, we come to that later, by Ukrainian clinicians, and further ERN coordinators statement. There is an ERN coordinator statement and a launch of the website in solidarity with European clinicians. Some ERN coordinators facilitate the transfer of patients with rare diseases and complex conditions needing urgent treatment to their healthcare providers. This has been done for our ERN to the center of Dr. Brugada in Barcelona. And every ERN has a work package specifically for Ukraine. And an example can be seen in the link below. The next slide. So our structure is given here. We are the coordinating team. So there's work package 1. We are responsible for dissemination and for the evaluation. And then the different work packages contain all the different activities that we do. The CPMS will be discussed extensively later. I will briefly show you the type of registries we have. I will briefly touch about training and education, and about the guidelines, writing guidelines, and adopting guidelines. And work package 8 relates to Ukraine. The next slide. This is our subdivision in thematic areas. We have 5. Thematic area 1 is familial electrical diseases, which is led by Elena, present in the meeting today. Work package 2 is on familial cardiomyopathies, led by Dr. Philippe Charon in Paris. He could not attend today. Work package 3 is special electrophysiological conditions, particularly in children, led by Dr. Georgia Bugada, present today. Work package 4 is congenital heart disease in adults and children. The children part is covered by Dr. Nico Blom in Amsterdam, and the adult part is covered by Dr. Annemien van der Bos in Rotterdam, in Erasmus University. And a final work package is other rare cardiac diseases, which is led by Dr. Alida Caforio in Padua, Italy. The next. We have an extensive collaboration with Patient Advocacy Group, EPEX. Abbreviation is EPEX, and this is the EPEX that we are currently collaborating with. The danger of showing a slide like this is that it might be outdated because there is continuously adding EPEX, and it covers most of the countries that are present in the ERN GUARD-Heart, and it covers different diseases as well. The patients and EPEX are very active. This was an activity during the last Rare Disease Day campaign, which is always the 28th of February. And this was the activity in 26, so this year. And there were patient stories published of 3 hours of our EPEX on the different diseases. So one is from Lorraine on inherited channelopathies, one is from Ruth, our chair, on arrhythmogenic cardiomyopathy, and one is from Celine on the short QT syndrome. The next slide. There is an NGO of rare diseases in Ukraine, which is a patient umbrella organization in your country. And they are in contact with all different ERNs. And so if you want to have patients connected or connect yourself with this organization, the website is there on this slide. Then some words about our own ERN organization. We like to follow the participants, the participant and the way our ERNs are active or not. We have made an indicator system which covers all the different domains that we are active, and healthcare provider can gain points for their activity, and we add the points every year and then show it in our board meeting. We have a half-yearly board meeting. We show it in our board meeting which healthcare providers are really active and which are less active. So it's a way of monitoring the activity of our members. Education is an important pillar of the ERN. It involves organization of patient meetings at the national level. As you know, Europe has a lot of different languages, so you can probably do this best at the local level, so in a specific country. The ERN facilitates this and also has money for the organization of patient meetings on a particular disorder. We produce layman abstracts. Every paper that is written by ERN centers is, we ask the lead author or the first author to write an abstract in layman language so that the patients can follow what is in this scientific literature. There is an educational webinars for doctors on a regular pace, and we organize fellowship and exchange programs. This is an example of this is the website of the layperson abstract. This is the introduction, and this is the state of today. We have a complete coverage of all papers published in 2022 and up to 24. We are working on 25 and 26. In total, there are 64 abstracts online now and 6 are pending. And there is active engagement of the EPEX because they see all the abstracts and they check whether the language is really as written for lay persons. And if not, they correct it. So before publishing online, the EPEC will have seen these abstracts. The next slide. In terms of research, we have quite a few web-based patient registries, so patients with specific rare diseases. We set up mutual research projects, and we have a collaboration with stakeholders in the rare disease community. As an example, the next slide is the different registries. First, what we do in terms of guidelines. This is a guideline from the ESC. Can you go back, Marie? So this is a guideline from the ESC on ventricular arrhythmias, which was written in 2022. We do not write guidelines ourselves as an ERN, but we actively contribute to the guidelines that are set out by the ESC. That is what our organization, the ESC, mandates. They do not allow other organizations to write guidelines in our field. So we follow the topics that the ESC chooses. But as you can see, indicated in yellow, there are many ERN members in this particular guideline on the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death. The next slide is about the registries. This is the different registries that we are currently running and that every center contributes to or can contribute to. In thematic area 1 on electrical diseases, it's on Anderson-Tawil syndrome, it's on Brugada syndrome, it's on calcium channel, it's on the CAL genes, it's on CPVT, it's on long QT syndrome, it's on MEPPC, which is an SCN5A related disorder, and it's on sick sinus syndrome and progressive conduction disease. The next slide is the different registries in the cardiomyopathy domain. So ARVC, and then a couple of the others are gene-specific, BAC3, FLA1, FLNC, LMNA, and PRKAG2 cardiomyopathy. And pediatric cardiomyopathies is a special one. A final one is on other rare diseases that includes Fabry, Friedreich's ataxia, rasopathy, and genetics and biopsy-proven myocarditis. And you can see from the names involved that there are many different centers actively involved in this as the coordinating center for these registries, and other centers contribute their patients to these registries. And these registries have as a spin-off, of course, a lot of research output. The next slide is the Ukraine-related activities. So there are online experts webinars. This is the first of that we do at the moment. We have already online ERN patient folders translated in Ukraine. At the right side of the slide, you can see the different topics. This was all done by Daria, and we will probably extend the number of diseases covered here. And there is an ERN exchange program with Ukraine, which led to one exchange in 2024 when a colleague, a junior cardiologist from Cardiff City Hospital, went to Barcelona and the hospital of Dr. Georgia Brugada. And they're still available, but we understand there are limitations for male cardiologists in Ukraine to travel outside their country. But in principle, the money is available to accommodate this. The next slide. So this is about CPMS, the Clinical Patient Management System. Ukrainian healthcare providers can seek advice on Ukrainian patients through ERN centers. A patient consent should be confirmed by the Ukrainian hub, that is the Omadit Children's Hospital in Kiev. And this is an important point because you really need a patient consent before putting all the data into CPMS. ERN centers can contact this Ukrainian hub using the mailbox as indicated. And the ERN coordination office can support identifying and facilitated contacts with different experts throughout Europe. And that will go through our contact email address as indicated. And this is how it works. So there will be a contact with the Ukrainian hub in Kiev, the one that I showed you before. There will be medical validation, and the patient consent form is mandatory. And then there will be connection with ERNs. The presenter will get a CPMS guest account so that they can access CPMS and upload the case. So there will be patient enrollment in the CPMS, and then there will be a certain time, which usually is a month or 2 months, where the case is open for discussion. This can all be online, but it can also be done through a webinar-like structure as we will do today. And then at some point, when the input of the experts has been given, the case will be closed and a document will be made and sent to the original presenter of the case, and the guest account will be deleted. But for a next procedure, you will of course be able to have a new guest account. And that is it for the moment. If there are any questions, we are of course ready to address them. All of us from the editorial, from the office, coordination office. I cannot see the questions, but Daria, you may be able to see whether there are questions in the chat.
Yeah. Thank you very much for the presentation. If you have any questions and you would like to ask or clarify something, please use the chat option to write it down. For now, I do not see anything. There is a person who thanks for your work.
Yeah.
Thank you for nice words.
Yeah.
Okay. But
Okay,
if you don't... Oh, wait, there is a question. Yeah. The question is, do you consider expanding ERN collaboration with Ukrainian hospitals?
Yeah, that is all. It all depends on the legal issues. Centers outside the European Union are not allowed to be part of an ERN. I mentioned the Brexit, and at that point there were many UK centers within ERNs, and they all had to be out of the ERN at that point when the Brexit was pertinent. So there cannot be a direct collaboration. You cannot be part of the ERN, also not as an affiliated member, because that has the same rules. This is not our choice. This is European Union policy. But having said that, there are a lot of ways to collaborate. So, for example, the webinars as we do today, the registries are also open to non-ERN centers. And research topics, any research topic is open to collaboration. So that it is just you cannot formally be a member of the ERN, but in terms of collaboration, there is a lot possible. Are there any plans to generate a new publication through collaboration? There are always plans on publications on different topics. So I think in every registry at the moment, there is a continuous output of publications. In general, the centers that contribute to the registries also have the right to pose a question, a specific research question, and they can use the data from the registry to address that specific research question. So if one of you contribute patients to, let's say, the CPVT registry, and you have a specific question you want to address, you will have access to the data from the other centers as well, and the questions can be addressed. So this is a general answer to that question, but it very much depends on a specific topic, which directions you want to go.
There is one raised hand from, there is one raised hand from Eloisa and one more question.
Okay, let's start with Eloisa Arbustini first.
Thank you. My question is on the opposite side. Suppose that we see Ukraine patients in Italy, and here we have only one family member, and perhaps other family members are there. According to the recent guidelines of the European Society of Human Genetics, theoretically there's the possibility of informing eventually relatives about the pathology, the disease that we have seen, and to perform some preventing or some screening in the families, in the rest of the families. I don't know if this is allowed, it's not a plan. in the context of the ERN. But we have many Ukrainian patients here.
Yeah, I'm not sure the ERN can play a role there. The Ukraine patients are referred by a Ukraine physician to Padua in your case. Oh, sorry, to Pavia in your case. And then I think by contact of the referring physician, you should inform the family members. I don't think the ERN can do that because we don't have the contact address either of these physicians nor of the patients, of course.
Okay, thank you.
I think that we can have 2 more questions until it's 5:30, and then if people have more questions, they can write it in the chat, and yeah, we will see if we will have at the end. So the second question, do you perform genetic testing for patients, or do they need to already have a confirmed genetic variant?
I think that is not the ERN as an organization does not do genetic testing, but individual centers may want to do that. I think it's just you have to reach out to individual physicians within a healthcare provider with interest in that particular topic, and then quite often it can be done, I believe. So there's no need for a confirmed genetic variant already. And a lot of that is still done in the research setting by many centers, including ours. And how can registry data be accessed? Is it possible to obtain registry data for study on valvular disease, for example? Now, valvular disease is a topic that is not covered in the ERN because it's not considered a rare condition, maybe except in congenital heart disease, but I don't know exactly. And there is not on every disease yet a registry. But as I mentioned, if you contribute to a registry, the rules of the registries are usually such that if you really contribute to the registry, you are able to address the registry with specific questions with the organization. You have to be in touch with the collaboration with the organization of that particular registry.
Okay, thank you.
Maybe we go to the case.
Yeah, thank you very much again for the presentation, Professor Wilde, and thank you for your questions. So now we will start presenting clinical cases, and I will start with clinical case number 1. So you should be able to see my screen.
Yeah.
Okay. I will be presenting clinical case in English. I also included some Ukrainian translations in green font on a slide. So yeah, Ukrainian physicians that want some clarifications, they could read it. So our clinical case starts in January 2025 when a 67-year-old male patient was consulted by a neurologist due to the cerebrovascular accident and was requested for cardiovascular screening. From medical history, we know that initial contact with cardiologist was 12 years ago. And at the ECG, we noticed asymptomatic first-degree AV block, left anterior fascicular block, and echocardiography detected ejection fraction of 60% without any dilatation. ECG for this patient at this point in January showed atrial fibrillation. There was an attempt for electrical cardioversions. It was unsuccessful. So in May 2025, echocardiography was performed with ejection fraction of 30–40%, moderately reduced, and dilated atria with mild insufficiency on the mitral and tricuspid valves. And here is a question: what was the reason for LV dysfunction in this patient? Here we might suspect cardiomyopathy, and we could wonder whether the reason could be ischemia, or maybe genetics, or maybe there could be some other reasons. So according to the clinical diagnostic workflow of cardiomyopathies that's been published in the cardiomyopathy guidelines from the European Society of Cardiology in 2023, we have our clinical scenario. We have suspected cardiomyopathy, and we also evaluated ventricular morphology and function. So we do have a reduced ventricle function. And what we still have to be done is ventricular scar or fatty replacement detection. We have to see what is the tissue characterization. And after that, we can make a conclusion what is exactly type of the cardiomyopathy in front of us, and then we could also evaluate some additional traits. So the next step was MRI heart for using ischemia detection protocol, and it showed dilated non-hypertrophic left ventricle with poor systolic function of 22%. Also, there was mid-myocardial septal fibrosis and a dysynchronous contraction pattern. Subendocardial perfusion defect in the mid-ventricular interseptal area, and while ischemia was deemed less likely, it could not be completely ruled out. So from family history, we found that there was no sudden cardiac death in the family, but there was cardiomyopathy in the family. And the next step for us would be to perform genetic testing. So genetic testing in these settings could be done in several ways. So the most popular probably is NGS. It's a next generation sequencing when we have a list of genes that could be associated with cardiomyopathy, and we test for mutation in this list of genes. But nowadays we also have full exome sequencing when we look into all exomes, or even full genome sequencing when mutation been detected in any location of the genome, including both coding and non-coding regions. So the genes that could be associated with cardiomyopathy, there's a lot of them, and some of the genes could be also associated with different cardiomyopathies. The most common genes that are associated with dilated cardiomyopathy are, for example, titin, that could be accounted for around 30% of cases. And separately, we would like also to show you ClinGen resource, so clinical genome resource that also present evidence-based assessment of genes that could be associated with cardiomyopathies. So here's presented a paper for genes associated with dilated cardiomyopathy, and ClinGen is evaluating all of the genes, all of the evidences that gathered for these genes, and make a decision whether there is definitive evidence, strong, moderate, or limited evidence. It is showing that genes that have definitive, strong, and moderate evidence, it just means that it's quite robust evidence that these genes are associated with cardiomyopathy. But as we can see from the slide, also a lot of limited evidence genes also been included in the panels. So for our patients, the genetic testing been done in September for the panel that included 59 genes, and the result was heterogeneous class 5 pathogenic variant in LMNA gene. So pathogenic variant class 5 is according to the CMG criteria, when class 4, class 5 is likely pathogenic and pathogenic variants, class 1 to are benign, and class 3 is unknown significance. Lemon gene is a gene that encodes proteins that located in nuclear lamina, and laminopathy is diseases that caused by mutation in lemon gene. They actually could be around 400 different phenotypes associated with mutation in lemon genes, and the biggest concern are, of course, severe risk of malignant arrhythmias, but also these patients have been shown with muscular dystrophies and congenital muscular dystrophies specifically. Beside that, patients been shown to have conduction defects. So as we remember, our patient started with atrioventricular block, and it is quite common for individuals with lemon mutation to have AV block. And the disease usually presents in young adults at the age 25-45 with near 100% lifetime penetrance. And also these patients sometimes receive potential prophylactic defibrillator implantation. So here as well, the same slide in Ukrainian. And as I mentioned before, that sometimes people could be prescribed with prophylactic implantations. This is also something that we see in our guidelines. So for example, if, of course, individual experience cardiac arrest or VT, and this patient has DCM, then they could have ICD implantation. Also, there is recommendations class 2 for ejection fraction less than 35%. But even if the ejection fraction not smaller than 35%, but they have high risk gene mutation, they could be assessed for risk using the risk score for the specific gene. And then they also could be prescribed with ICD implantation. So which risks genes are actually high risk? So these are PLN, DSP, lemon, filament C, TM, EM43, and RBM20. So this is a list of genes that have been presented by the guidelines in 2023. And for our patient, we have lemon risk VGA calculator that also include parameters that have been associated with worse prognosis, such as male sex, non-missense lemon mutation, atrioventricular block, NSVT, and also ejection fraction. And by estimating all of these parameters, we could get a risk of life-threatening ventricular arrhythmias at 5 years. For these patients, the risk of malignant ventricular arrhythmia over 5 years was 16.6%, which led to the referral to the multidisciplinary team for rhythm and ICD prevention. And they also started with spironolactone 12.5. But considering that this patient needs resynchronization, he was prescribed with CRTD. And this is ECG of this patient before the implantation. So as we can see, there's atrial fibrillation. And the ECG after CRTD implantation with paced rhythm. Echo shown later moderate systolic function. So there was somewhat increase of the systolic function, 30-35%. The left ventricle was still dilated, severely dilated left atrium and right atrium, and remained regurgitation. There also been performed exercise stress tests and Holter monitoring. On exercise stress tests have been shown multiform PVCs, and also there was a lot of premature ventricular contractions at the Holter monitoring, with 4 episodes of NSVTs. And since this individual was diagnosed with and detected with lemon pathogenic variant, we also have to consider genetic family screening in their family. So according again to the guidelines, if we have PLP variant shown here on the left, we have to consider cascade clinical and genetic testing. And then based on the varying status in the family member, we will have to continue long-term follow-up, even if they do not have phenotype as of yet. And if they are variant negative, then we have just discharged them. There is, if the patient do not have pathogenic or likely pathogenic variant, then we will have to see their family screening based on their phenotype, but then we have also to consider other causes of their cardiomyopathy. And in conclusion, our case was presented with 68-year-old man with DCM due to pathogenic lemon variant that had 33 on the TE, that was previously 22%. There was permanent atrial fibrillation, severely dilated left atrium, list of malignant ventricular arrhythmia 16.6% that led to the CRTD implantation, and medication patient received then metoprolol due to NSVT and also Entresto. And I would like to hear if you have any questions or thoughts on this case. Thank you. So I'll stop sharing my presentation to see the questions and to see the chat. Yeah, what was the
may I ask?
Yes.
Thank you so much, Daria. Interesting case. I am Elena Fedota, professor, Kharkiv. If this is a Ukrainian patient, where was the patient tested?
This was not a Ukrainian patient. This was a patient from the Amsterdam UMC, and yeah, so he would. So, and I will also partially answer the question from Arthur Wilde about heart rate during AF without drugs. So I will not be able to answer this question because the primary cardiovascular examination and management being done in another hospital, and the patient already continued at the Amsterdam UMC after the genetic testing.
I was just asking because with the slow heart rate during atrial fibrillation at age, first of all, atrial fibrillation at age 50 is unusual because it was 12 years before the presentation now, so that's roughly 50 years old. Atrial fibrillation
yeah, and they have
unusual.
element.
Yeah, but that was not known at the moment I wrote this question. Yeah. But that is indicative, that's predicting a Lemon variant. And the other thing I would like to comment is that there are variants that are an exclusion to the guidelines, I would say. We described one ourselves, which is a Lemon variant, which is not as malignant as all the others. There is a founder variant in Canada with very similar characteristics. So if this is a large family with a lot of individuals affected and no sudden death, then I would not immediately jump on a defibrillator. I would not use the calculator because the variant may be one of these exception variants that is not that malignant.
Okay.
But that depends on the family size, and the patient himself is also rather old for this problem.
Yeah. Yeah, I think this is here comes the help of the ERN GUARD-Heart and experts, because for the things that is not written in guidelines. Okay. Then Malou van de Boegaert writes, I think a lot of centers wouldn't perform genetic testing in a patient of this age with ICVA and atrial fibrillation, even with decreased ejection fraction, and just start GDMT after negative CEG. What is your take on this? When would you advise them to look further? I would refer these questions probably to the experts.
Well, Malou is an expert herself, and she knows the answer. The issue, of course, here is at age 50 or 52, atrial fibrillation with a slow ventricular rate and a narrow QRS complex and a decreased LV function is a good reason for genetic testing, because it has all the elements of a genetic substrate. You have to exclude ischemic heart disease to start with. That was done. And if you have excluded it and you are dealing with a non-ischemic cardiomyopathy with these characteristics, there is a good indication for genetic testing, I would think.
Yeah, and I would add that in this case, you had family history of cardiomyopathy.
Yeah,
so
of course.
That's also, because I believe sometimes, I mean, oftentimes, people are not asking for family history. One on this webinar is very knowledgeable, and they always do, but when you go outside this group of people with special sensitiveness for these diseases, family history is normally not asked for. So I think all these factors would have made me go also for the genetic test, even in challenging situations. So.
Yeah, and also the after, I didn't include it in the slides because we have limited time, but the family, the patient has also younger brother, 50 something years old, and he also was has the same detected variant, and he also was prescribed with ICD implantation. We have
Eloisa.
Question. Elisa.
Very simple. I probably missed the variant. Do you remember, Daria, what was the variant in Lemming?
Yeah, it was a missing variant. It was actually it was the founder variant that present very commonly in the Netherlands.
That is 330.
Yeah.
At position 330. I don't know the amino acid change, but it's.
Yeah.
Okay.
So do you know where genetic testing can be done in Ukraine? Do we have information on that? Is anybody in the meeting who can give information on that? So the question is, do we have any information regarding centers in Ukraine that perform genetic testing for cardiomyopathies? Can anybody answer that question?
Yes, of course. In Lviv, in lab Leogan, we can do some NGC panel for cardiomyopathy, especially I have patient also with hypertrophic cardiomyopathy, and we do this tests, but it's not free of charge for our patient. And it's very difficult when we found some mutation, we must do family member. It's too expensive for this patient, especially cost 350 euros per patient. If my question is also actual for us, because our patient cannot possibility to do this test by self.
Well, I can also maybe, this will be, I think, the last questions that we'll answer for the case, because, yeah, we have 13 minutes left and one more clinical case. But we have, our dilated cardiomyopathy registry, and we also do research for dilated cardiomyopathy. So we're recruiting now patients for whole genome sequencing. So if anyone needs to be done this testing, then we can see whether they could be eligible, like, for the research. And then, we can do that under the umbrella of the research. So, you could send me an email and then we could see what could be done.
Okay, we go to the last case.
Okay, and then, Dr. Malou van de Boegaard will present us the second case.
Yeah, thank you very much. I think now you can see my screen. So my name is Malou van de Boegaard. I'm a cardiologist at Amsterdam University Medical Center, and I will present you a case on hypertrophic cardiomyopathy, in which there wasn't a mutation identified. So I like cardiomyopathy. Sometimes I talk about them, and sometimes that is funded by some companies. This is a case of a patient that we know already for 16 years. So it's a 24-year-old woman who was first referred for evaluation of a systolic murmur that was detected after a pregnancy. And her other medical history did only mention depression. But there was a family history of a sudden cardiac death in her maternal brother at the age of 30, and she told me that the family was evaluated for Brugada syndrome, but nothing was found. And no other evaluation was done in the family members. So when she came to the outpatient clinic in 2010, she doesn't have any cardiac complaints. She does tell us that she sometimes, or she had a collapse once before with the gastroenteritis, but other than that, no cardiac symptoms. She has a normal blood pressure, normal heart rate. She doesn't take any medication. And this is her EKG on the first evaluation. So there are some changes that shouldn't be there, I think, in a 24-year-old, but on the other hand, it doesn't directly give you a diagnosis yet. So an echo is made. She has normal biventricular function. There is some turbulent flow in the LVOT, but no gradient measurable, and the septum thickness is 12 millimeters. Because the cardiologist that evaluates her then thinks, well, it's a borderline EKG, and the LV wall thickness for this age 24-year-old is also a bit large. They also do an ambulatory 24-hour monitoring and do exercise testing, but all of these evaluations are normal. And they say, well, it's probably ejection murmur with mild anemia after pregnancy, and advise her to do a reevaluation in 3 years. Then, of course, as 24-year-olds with young babies are, she doesn't come back in 3 years. But then 4 years later, she was running to the train and has a syncope while running. It was a hot day, so maybe she was a bit dehydrated, but we evaluate her in the emergency room. Then she has a normal blood pressure, a little bit higher heart rates, and the systolic murmur is heard that increases with Valsalva. EKG is actually unchanged. You still see that there's some R wave missing in V3 and also Q waves in V4 to V6, but she doesn't meet the criteria for hypertrophic cardiomyopathy. And she is being held in the hospital for 24 hours for rhythm monitoring. There are no arrhythmias seen, but an echo is made in which the turbulent flow in the LVOT is still visible, and now there is a gradient of 32 millimeters mercury with a septum of 14 to 15 millimeters. So immediately CMR is performed, and you see the image here on the left side or right side for you, probably on the screen, in which you see that there is the turbulent flow in the LVOT. And the septal thickness of 15 millimeters is confirmed. I also see some fibrosis in the image in the bottom, in the most thick part of the septum, one segment of the basal antral septum, and also the inferior hinge point. So now the conclusion is that there is probably a hypertrophic cardiomyopathy with a mild obstruction, and she has a syncope with high risk features. Now the question is, well, what is her diagnosis? And here it's very important, I think, that you do a good phenotyping. So everything here points in the direction of a true hypertrophic cardiomyopathy with asymmetric left ventricular hypertrophy with an LVOT obstruction, also systolic anterior movement of the mitral valve. But of course, you also have to exclude infiltrative diseases, storage diseases, and syndromic diseases like Noonan. Well, she was evaluated for this, and none of these other features were there. Now, because we think it's a true hypertrophic cardiomyopathy, the HM risk calculator was used. In 2014, it looked a bit different, but now in the current guidelines, the QXMD calculator is advised. It's exactly the same as it was in 2014. And when you put in all the factors of these patients, you see that she comes at a risk of 3.27%, and an ICD is generally not indicated. And what you see here is that a genetic mutation is not part of the calculator. So regardless of whether you are a carrier or family member or just the first one in the family that has this disease, you get the same number out of here. What we do then is we start on beta blocker therapy. An implantable loop recorder was advised because it is a high risk syncope. And we advised genetic testing. This is from the 2014 guideline, which shows that a 5-year risk of ventricular tachycardia is low. ICD is not indicated. And when you look at the current guideline, you see that there is one addition that shows the clinical risk factors, which, for instance, are one of the most important things is the amount of fibrosis on cardiac MRI, and gives you still a class 2B indication for ICD implantation. And when we do genetic testing in hypertrophic cardiomyopathy, we do the full panel that Daria also showed, so the 59 genes, but what we most commonly find are sarcomeric genes here in the middle of the presentation. There are some other emergent HM genes that we find more often now that we start looking for them. One of the most important ones is the LPK3, and also other genetic modifiers that are found in some populations, for instance, the PLN, the Romanian population. But we also see a lot of people that develop HM at an older age that don't have any mutations. They do develop LVOT obstruction, and it's probably a combination of lifestyle, epigenetics, and maybe a polygenic risk score. What you see here, the monogenic diseases usually present earlier, and the polygenic versions at older age. So we follow up this patient. She's now 28 years old, and 4 months after the loop recorder implantation, she comes back and she reports lightheadedness while she was playing with her daughter. Then a loop recorder readout was done, and 38 beats of non-sustained VT at 119 beats per minute was found. Genetic testing now is also come back and shows no pathogenic variants, but when we put in her new non-sustained VT in the calculator, she now is at a risk of 7.3% for ventricular tachycardia and sudden cardiac death at 5 years, and ICD should be considered. So she gets a subcutaneous ICD, and a beta blocker is up titrated. And then for a whole time, it goes very well. So we are now in 2020. She's 34 years old and now 24 weeks pregnant with her second daughter, and reports progressive shortness of breath, dizziness, palpitations, with the up-titrated dose of metoprolol at 100 milligrams once daily. She has now had a very low blood pressure of 19/60 with a slow heart rate of 61. And the SICD is working properly. She doesn't have any therapy in the past years. EKG is unchanged in these years. And when we now do echocardiography, we see that there's a typical reversed curvature septal hypertrophy with a septal thickness of 18 millimeters. And when we look at color Doppler, you see that there's systolic anterior movement and LVOT obstruction with the resting gradient of 47 millimeters mercury, and with Valsalva that increases to 68 millimeters mercury. So she has now a symptomatic obstructive hypertrophic cardiomyopathy during pregnancy. There's a maternal score of 3. And the question is, well, what should we do now? Because we, of course, have the classic treatment for obstructive HCM, but a lot of these medications are not possible during pregnancy. So calcium channel blockers are not advised. And disopyramide also in the first 2 trimesters is not advised to be given. So actually the only next step after beta blocker is septal reduction therapy. She is closely monitored during pregnancy, advised to do as little as possible, and eventually with cesarean section she has an uncomplicated pregnancy with a higher dose of beta blocker, but afterwards she is still a persistent NIA class 3. Actually cannot do anything with the baby, only sits on the couch. And when we do echocardiography, a resting gradient increased to 68 millimeters mercury, and with Valsalva it goes to 100 millimeters mercury, with also severe mitral regurgitation. So she's discussed for advanced therapy, and then decided to go for alcohol septal ablation. Which is in the guideline both then in 2020 and now that should be performed in centers that have experience with this type of intervention, and should only be done in patients with a provoked or resting gradient of more than 50 millimeters mercury, which are NIA class 3 to 4, despite maximum tolerated medical therapy. So that septal reduction therapy is done, and then at first, in the first few months afterwards, she feels good, but when we follow her up the years after, she still gets complaints, NIA 2 to 3 again in 2024, and that's the first time that I see her. So then again, she has symptomatic obstructive hypertrophic cardiomyopathy despite this previous alcohol septal ablation. And now with the current treatment options, we go back to the guideline. Because of her low heart rate, low blood pressure, there's no room for addition of calcium channel blockers, and we decide to start her up on mavacamten. And then this is her MRI. You see that there are some artifacts from the subcutaneous ICD, but you see that the LVOT obstruction is completely lifted here. And what I liked with the latent gadolinium enhancement images is that you see the scar from the septal alcohol ablation here in the middle. But the fibrosis from the hypertrophic cardiomyopathy itself has not really increased. And now this is her echo at the moment. So she was here in the outpatient clinic 2 months ago. She says, I haven't felt like this since I was 20 years of age. And actually all the complaints that I had that were always put on my low blood pressure have also come completely away. We are still waiting for new genetic results, should have or could have changed changed the course of action that we should have taken. So my take-home messages for you are that it's important to invest in phenotyping. So make sure that your phenotype is a true hypertrophic cardiomyopathy. And as you can see, even a mild phenotype without an identifiable genetic variant can progress to a severe phenotype in need for advanced therapy, so septal reduction therapies or cardiac myosin inhibitors. And here, it doesn't matter whether this patient has a genetic variant. It does not change your treatment strategy. So the drug strategy and the ICD implantation should have happened regardless of a mutation at this particular point in time. However, of course, there are new genetic or gene therapy strategies coming up in the near future. So maybe in the future this advice will change, but for now, this is the way to go. Thank you.
Thank you very much for the very interesting presentation. So I see that Mary has written that due to time shortages, another presentation from Professor Wilde will be recorded and sent separately. And I do not know if we will have time for live questions now, but everyone could write questions to my email or to the email of the person that sent the invitation, and then we will discuss this. We will send the answers through the email. But yeah, I don't know if experts have time, if we have 1 or 2 questions now offline.
I have, but I'd like to emphasize that the 2 cases presented are just examples of what we can do with this type of webinars and with this type of, with using CPMS. So if you have any case in your country that you would like to present to experts in Europe, you're welcome to present them in this, to this format.
Thank you.
I'll just say 2 words. The case was fantastic. There are so many things that we can discuss, and it's unfortunate that we don't have time. So I do suggest that whatever comment you want to do, you write to Malu, Daria, or the others, and come back with the comments, because we could talk about the pregnancy, the management of septal reduction therapy, decisions, and so many things that can be discussed that it's actually a pity that we don't have more time.
Yeah. Agreed. And I try to talk fast, as I do usually. So, but it's a real case. So nothing of this was made up.
Yeah.
And let me ask Elena, would you prefer alcohol ablation or a Morrow procedure?
So I prefer myectomy, but we do have a super good and an excellent surgeon. We only consider alcohol septal ablation if the patient doesn't have good characteristics to undergo this type of surgery. But now the surgery is becoming less and less invasive. So in the past 10 years, I think we've had 1 alcohol septal ablation. We had last week the sesame technique done for the first time in our hospital. So yeah, I think what we need to do, and especially now that we have cardiac myosin inhibitors, is to have very few but high volume centers for septal myectomy, because the problem we will face is that surgeons will start doing less and less, and the expertise will be worse. So rather than having, 4 centers in Spain, 4 in Germany, maybe it makes sense to have 1 in each country or through Europe. I mean, we should facilitate patients moving also cross borders.
Agree.
Yeah, and if I can add, I also think in this case I would have chosen for myectomy because of the mitral regurgitation, which you don't address. It was not just some, we also still see it now. And I think that's one of the reasons that she still had complaints afterwards.
If we have 2 seconds, I wanted to ask or make a comment. I love that you share the pregnancy, and I think this is something that needs to be discussed with young women when they come to our clinics the first time. And usually in patients with cardiomyopathies, I think that especially now that we sometimes decide to go on cardiac myosin inhibitors and we may need to stop them before pregnancy. I think it may be useful to perform a stress echo in these patients. So you increase the volume, and this way you kind of try to simulate what a pregnancy would do or find the worst case scenario so that you can be better prepared for the hormonal and volume changes that the pregnant woman undergoes. And yeah, I think that's, I don't know if that's standard practice in your case. I mean, I know this case probably came to you later in the pathway, but I think that for those patients that we have before they get pregnant, maybe this is something that can be considered.
Yeah, agreed. So we don't do standard stress testing. We do, for all patients that are being evaluated for cardiac myosin inhibitors, we let them do 20 squats, for instance, but that's not the same as doing exercise bike testing to simulate the situation of a pregnancy, maybe, so the volume increase. So I think it's a nice idea. And one of the other things I was thinking, I heard that the next line of cardiac myosin inhibitors are now also being tested in women that are pregnant. So maybe, that won't be an issue in the future anymore. But
so the good news is that the EMEA, so in Europe, the technical file for Aficamten is not contraindicating pregnancy. It's not the same as allowing it, but it's basically says if a patient gets pregnant with Aficamten, you need to evaluate risk benefit and decide whether to stop it or not. And they're mandating like really close follow-up of the patient and the fetus. It's not exactly that they're doing testing in pregnant patients. Some pregnancies have occurred in patients with Aficamten, and apparently no teratogenic effect or adverse effect has happened. But at least someone's opening the door. It may be too early to consider them safe like we consider beta blockers.
Exactly. Yeah.
Okay. This is a great discussion. Indeed, we do not have that much time to continue. Maybe Arthur, I think
we can easily set up a second webinar, and then I have the presentation about general issues with genetic testing, and we might add a case from Ukraine itself if one of colleagues present has a specific case he or she wants to discuss. We can add that, and we can do that immediately after summer, I would propose.
Thanks. This is a fantastic idea. So for all of the Ukrainian colleagues that are listening, and if you would like to present a case, I think you could email to the email that's mentioned in the chat, contact@guardheart.ern/net.eu. And thank you everyone for sending presentations. Thank you experts for sharing this webinar. And then I will see everyone out of summer.
Thank you. Very nice to see you all.
Bye-bye.
Thank you.
Thank you.
Bye.
Thank you very much.
Have a nice day. Bye.